Great. Well, welcome everybody. We are excited to have each of you join us today as we discuss the new Bree report on diabetes care. My name is Emily Noodleman, and I'm the Transformation and Community Partnership Manager at the Bree Collaborative. Each year, the Bree develops reports on key health topics facing Washingtonians. Our members identify healthcare services with high variation in the way that care is delivered, that are frequently used but do not lead to better care or patient health, or that have patient safety issues or inequities. For most topics, we form a work group of subject matter experts and leaders to develop evidence-based guidelines. The guidelines take into account existing quality improvement programs and the work done by other organizations. Our reports provide guidelines for multiple audiences, such as clinicians, health delivery systems, plans, purchasers, and others to encourage collective action to promote optimal health for Washingtonians. The Bree Collaborative forms work groups to bring together individuals across the state to engage in providing their expertise to help craft the report. We greatly appreciate our work group members' willingness to share their time, knowledge, and expertise with us. And today, we look forward to hearing from some of them and sharing the report with you all. We hope by the end of the meeting, you will leave with a greater knowledge of the Bree Collaborative and the report on diabetes care, learn more about collective action to promote the health of people at risk for or living with diabetes in the state, and a deeper understanding of what different audiences within our healthcare ecosystem can do. During the presentation, we will provide an overview of the report, hear from individuals representing different audiences within our healthcare ecosystem and on how they intend to implement the guidelines in their role. We will also then transition to a Q&A, and at the bottom of your screen, you should see a box that says Q&A. Please place your questions there so we may review them and ask them to our presenters during that time. The webinar today will be recorded, and we plan to send out the slide deck and the recording to you all who signed up to attend the event via email. The recording will also be posted on the Bree webpage. As just a background to the issue, diabetes is a chronic disease that results in elevated blood sugar, which over time leads to serious health complications such as heart disease, vision loss, and limb amputation. Diabetes is the 8th leading cause of death, with an estimated annual excess cost of $6.7 billion in Washington. Oh, sorry, 7th leading cause. Individuals across the age spectrum can be diagnosed with a diagnosis among children and adolescents becoming more prevalent. 1 in 5 Americans are unaware they have diabetes, and 8 in 10 are unaware they have prediabetes, which are similar rates we see in Washington state. The guidelines in the report focus on care for people with or at risk for type 1 or type 2 diabetes and prediabetes. Diabetes was selected by the Bree Collaborative members in September 2022, and a work group of clinical and community experts met from January 2023 to January 2024 to help develop the report. The focus areas of the report are on team-based care and empanelment, population health, and financials. This is a list of the different audiences guidelines have been developed for in the report. Those in bold are who you will hear from today, and additionally, somebody from the community setting describing a way healthcare professionals can engage with the community. Our speakers are Dr. Norris Kamo from Virginia Mason, Nicole Treanor, also from Virginia Mason, Dr. LuAnn Chen from CHPW, Susan Buell from YMCA of Tacoma and Pierce County, and Glenn Puckett from Delta Dental. So I'll pass it off to our first speaker and invite Dr. Kamo to come off to talk about how clinicians can use the guidelines.
All right, well, thank you so much, Emily. And I was fortunate to lead this subgroup, and I'm quite proud of all the work we were able to do in a collaborative manner. So next slide, please. All right, so I'm going to talk about the clinician's perspective, and it's kind of the ideal, right? We're all working towards improving care for individuals with diabetes, and so by no means are we perfect as a provider group, but this provides kind of a North Star for clinicians. And so I wanted to talk from the clinician's perspective and how the Bree guidance can inform what we do in clinic. So I'm going to stratify based on patient populations. But first of all, I wanted to review the importance of person-centered communication and person-centered care for our patients. And this comes from the chronic care model, which was created through Group Health and the famous Ed Wagner and his group, right? But here's an example of how we want to change and evolve from problematic to preferred verbiage that is respectful of individuals, right? So instead of calling someone diabetic, right, it's a person with diabetes, right? Some problematic language is non-diabetic or normal, right? Well, that means, you know, if I have diabetes, do I have a problem, right? So part of what we need to do is work on the foundation and understand our patients' preferences, individual characteristics, their social environments, et cetera, right? Next slide, please. So in terms of what we can do for all patients, first thing is screening, right? So according to the ADA, 164,000 individuals in Washington state have diabetes, but don't know it. And we've all encountered these individuals in our clinical practice. So fundamentally, we want to screen for diabetes per the ADA, USPSTF guidelines, with special attention to high-risk populations, folks in the BIPOC community, individuals with HIV, and there's a few other populations. But we've all been surprised at, the folks who come in, maybe get their urgent care, they bounce in and out, and we never screen for diabetes. And so in our organization, we have an initiative called Attention to Prevention, right? And so every encounter is an opportunity to address USPSTF guidelines. If you're not able to do it at your visit in, let's say, an urgent care or acute care setting, refer on so individuals can establish primary care. Another important aspect is psychosocial assessment, not only depression screening, anxiety screening per USPSTF, but also doing an SDOH or social determinants of health assessment. And there's guidance on that from a prior Bree guideline. So an example is assessing for food insecurity. Third element is overweight obesity evaluation. And the 2024 ADA guidance says consider other measurements of body fat distribution other than BMI. So things like waist circumference or waist to height ratio, because you can't evaluate for overweight obesity just based on eyeballing an individual, right? There's objective measurements and there's measurements beyond BMI. Next slide. All right, so about 2 million individuals in Washington State have prediabetes. Really important to develop management plan and person-centered goals. So these include the fundamentals of nutrition, physical activity, weight management, medication risks, and benefits, and then referral to treatment. And so you're going to hear the Susan from the YMCA talk about the diabetes prevention program, what they've set up, but do you have a robust referral system for referring to DPP, whether it's through the Y or some other organization that is certified? There's also the special diabetes program for Indians run through the Indian Health Service. You also want to consider the multi-component behavioral treatment as recommended under USPSTF, and then various organizations have community health workers or partner with them, and we want to use this as a launching pad for creating a robust network of community health workers in conjunction with the Department of Health and other organizations. And next slide. And then there's 582,000 individuals in Washington State who have diabetes. And so it's kind of 4 components we include in the guidance. So we're working with a diabetes care team and following clinical pathways that are based on ADA guidance. And there's the diabetes self-management and support and education services that you'll hear from Nicole, the specialists, eye care, going to hear about dental care, podiatry, behavioral health, community health workers again, and the ability to communicate with external providers. We're getting better and better at that. in the era of EHRs. It's taken 10 or more years, but we're seeing records and are able to communicate electronically with external providers. Again, the importance of comprehensive psychosocial assessments and things like PHQ screening, GAD screening for depression, anxiety, but also something that's emerging is assessment of diabetes distress. How much does this diagnosis cause distress in your ability to function? And there's a scale called the PAID scale. There's a few others that we want to emphasize to understand the whole patient. And then, of course, the plan for glycemic monitoring, pharmacologic management, care pathways again, diabetes devices, that it's a quickly evolving field. We know that Medicare has changed their guidance for coverage of CGMs. And if you didn't know already, there's the HTCC, Health Technology Assessment Committee, that has guidance on diabetes devices. And hopefully they'll keep up to date with emerging evidence. And then lastly, using registries to track gaps in care. Of course, there's our HEDIS measures like A1C control, blood pressure control, eye exam, kidney health, immunizations, social needs. But hopefully in your system, we are able to both do what we call in-reach for the individuals who are in clinics, seeing you for either diabetes or other conditions, and then outreach for folks who are out of care that we are responsible for and have had encounters in our clinics. And next slide, please. And so I wanted to reemphasize DSMES, Diabetes Self-Management Education and Support. And there's 4 critical times where an individual needs to be referred for DSMES. So at diagnosis, annually, and or when not meeting treatment targets, and transitions in life and care occur, and when complicating factors develop. So that we want to drill in to every clinician's repertoire. And they help with education on self-management medications, lifestyle options, referral for support. And next slide. And team-based care. So we're seeing more and more of this in not only diabetes, but hypertension management, chronic condition management. And here's an example of a meta-analysis that looked at various randomized controlled trials comparing usual care versus team-based care. And you can see on the table on the right, the improvement in glycemic control, blood pressure control, lipid management when we function as a team rather than try to treat individuals alone. And next slide. And I think that's all from my presentation. I'll turn it over to Nicole.
Yeah, thank you so much, Norris. Well, now you're right, transition to Nicole and have her come on to talk about how teams and ambulatory care settings can use the guidelines.
Thank you so much for allowing me to present with you today. And so what I wanted to highlight is that in chronic care management, there is always a direct relationship between patient behaviors and clinical outcomes. And I think diabetes probably highlights this more than other diseases. And so really at the heart of it, we know that it is the patient who has to manage their disease. And it's the healthcare team that has to provide the tools to that patient and help them adapt over time. When we look at past models of medical care, often there was more of a paternalistic model in which the primary care provider was at the center of the healthcare team, providing treatments and recommendations to the patient for that patient to follow. But if we look at the increase in fee-for-service-based models, the amount of time that primary care providers are being able to spend with their patients is decreasing more and more. And this highlights the need for those teams to be developed within healthcare systems. The benefit of having team-based care is that you have the expertise from a group of individuals at the disposal of our patients, but also it allows for that team to continue to reinforce the plan of care and the goals with the patient at regular intervals to make sure that they're staying on target with those. And so now when we're looking at the team for diabetes care, the person with diabetes and or their caregiver is really at the center of the team, still with that strong relationship with the primary care provider, but now supported by the team as a whole. Next slide, please. So we looked at who should be part of the team. And the recommendation is that at minimum, that team should include a nurse, a clinical pharmacist, and a registered dietitian for the patient to be able to interact with those individuals. Strongly recommended that we have interaction with a certified diabetes care and education specialist. And these are the people who are typically facilitating that diabetes self-management education and support. Then we have ad hoc members of the team, depending on the needs of the patient. So again, that might include a mental health specialist, social work, care managers, community health specialists, and then referrals to whatever specialties that patient needs, whether it be endocrinology, podiatry, eye care, dental care, etc. When available, it would also be beneficial to have a care coordinator on the team to help facilitate that management for the patient. So next slide, please. The Bree report also emphasizes use of the chronic care model or the collaborative chronic care model. And there's quite a bit of research and writing about this elsewhere, and there are links within the Bree report. But what we know about the chronic care model is that it's meant to foster the relationship between the patient and the healthcare team. And so some of the aspects of the chronic care model that the Bree report highlights are the use of patient registries to assess and manage care gaps within our healthcare populations, within the populations that we take care of, and use of these registries to help outreach and scheduling of those patients, making sure that they haven't fallen through the cracks, and if they have, making sure that we're getting them back in to take care of them. Also, the use of electronic health records, which help facilitate these patient registries, but they also help us track the progress that our current patients are making and help facilitate communication between members of the team. The chronic care model, it also supports the use of decision support tools. And so typically these are tools that are linked to evidence-based guidelines and encourage participation with patients in shared decision-making, such as to help determine treatment modalities. And so the example provided is from the Mayo Clinic looking at pharmacologic options for diabetes care, and that model can be used in conjunction with the patient to help determine what might be best for them. And then finally, one of the aspects of the chronic care model that I'd like to highlight is the need for self-management support. Next slide, please. And so I think those in healthcare would all agree that in the past 2 to 3 decades, there's been tremendous advancement in the pharmacotherapies available and diabetes technology available to our patients. And by all means, we should be taking advantage of these therapies. But as these therapies have advanced, it hasn't necessarily correlated with an increase in clinical outcomes for our patients. And so our patients still continue to meet their clinical goals and prevent complications. And so this highlights, going back to the fact that treatment of diabetes really involves a key behavioral component. Self-management support is really important. And so under this, we look at making patient-centered or person-centered goals, identifying challenges and barriers to meeting these goals, and trying to equip our patients with problem-solving skills so that when these challenges arise, they're able to tackle them without necessarily the guidance that we're able to, that one-on-one on a daily basis. There's an encouragement for self-monitoring so patients can have a better understanding of their own responses to various triggers, and then regular follow-up with the healthcare team. I think, again, working in with diabetes for a long time now, there's always times where patients say, I initially got the recommendations from my doctor or my educator, and I was very excited, I was implementing them, and something in life popped up, and I fallen off track. And so that's where the regular follow-up with various members of the care team is there to make sure that we're just helping them get back on track if they have fallen off track. So next slide, please. Looking more closely at developing patient-centered or person-centered goals, we have this graphic from the ADA Standards of Care. And so person-centered care typically assesses patient preferences and values, cultural norms, their lifestyle, work and education factors, or school factors, I should say, social determinants of health, and other comorbidities to help make treatment decisions for our patients, and using that collaboration between the patients to determine what is best. The model also looks at when it's time to create a management plan for that individual and implement that plan, that there's access to diabetes self-management education and support and regular follow-up with those individuals. The other thing I'd like to highlight about this model is setting goals. And so I think in healthcare, it's pretty well established that we set SMART goals with our patients, but I would like to also emphasize avoiding the use of preset goals and really trying to individualize goals with our patients. And then using flexibility in adjusting those goals over time if they ended up not being right for our patients or patient circumstances have changed. And then finally, avoiding an all or nothing assessment of those goals. Going back to what Norris was talking about is our use of language, avoiding the use of non-compliant or not adherent to make sure that it doesn't appear that we are blaming our patients. And I would like to point out more than just, or in addition to the words we speak to our patients, now a lot of patients have access to our charting. And so in our organization, our patients can access their records and what we've documented. So be careful about the language that you use in documenting patient encounters as well. Next slide. And so when we think about how to incorporate team-based care and the chronic care model into our daily work, this depends largely on the organization that you work with, whether it's a large-scale health care practice or an individual practice, the staffing that you have available, the locations of where that staffing is at. But when accessible, we would like to recommend the use of shared medical appointments. However, one consideration is that financial viability is a concern. And so some of those individuals those ancillary teams may need to be able to bill for services, and therefore shared medical appointments may not be able to be facilitated. If that's the case, our workflow falls back into a referral-based service. And we just want to make sure that when using referrals, that we are able to maintain communication between all members of the healthcare team. But again, with an emphasis on referrals for diabetes self-management education and support, medical nutrition therapy, the National Diabetes Prevention Program, or the Special Diabetes Program for Indians, and then of course, any other relevant specialties that our patients need. And next slide, please. And just to finish up very briefly and repeat what Dr. Kamo said, is that we do need to put in place structures for being able to screen for food insecurity as well as other social determinants of health. And the concern is that for patients who have limited funds, there may be times where they are choosing to purchase food for themselves or family versus medications, and therefore are not able to adhere to medication recommendations, or they may choose not to take medications when their meal intake is inconsistent and they are concerned about hypoglycemia or other side effects that may occur from taking medications while unable to eat. So it's important that we then develop referral strategies for social workers or care managers to help address these needs. So I appreciate you letting me speak today. Thank you so much.
Thank you so much, Nicole. We really appreciate you sharing that information with us. We'll now transition to Dr. LuAnn Chen from CHPW to talk more about how health plans can use the guidelines and using some examples of what CHPW is doing.
Thank you. I'm really happy to be here, and it was really exciting to work on this Bree work group. So I wanted to mention I'm a family physician. I've taken care of a lot of patients with diabetes, and I wish I had known what I know now after being on this work group and about all the supports that are available for patients with diabetes. So I'm going to tell you a little bit about how our teams at CHPW have used and implemented most of the Bree collaborative diabetes recommendations to support members and providers to improve diabetes care. So the Bree recommendations have given us a concise list of best practices for health plans, but we also have gotten ideas from recommendations for the other groups, other than just health plans. And the Bree recommendations have helped us to clarify and prioritize our work. The checklist has helped the different teams identify and recognize work they are already doing, and it's helped other teams to realize the division of labor. So next slide. This is just a little bit about Community Health Plan of Washington. We were founded, well, we are very very focused on the community, very connected with the community throughout Washington. We were founded and we are governed by community health centers with roots in the social justice movement. We focus on the whole health of our members. We are local, not-for-profit, and any profits go back into the Washington communities and the community health centers. Our local staff and board are part of the fabric of the communities we serve. So this little diagram of Washington has the 21 community health centers, and that they make up our board. And our integration with community health centers allows us to work hand in hand to break down barriers to care, focus on whole person health, and advance equitable healthcare for all. So next slide. The plan benefits are structured to promote access to medically necessary care, to break down barriers. So supports that we have specifically for members with diabetes. Each of our members is assigned to primary care providers. The care is coordinated with the network providers. There are no co-pays for visits for diabetes care management, including retinal exams, labs also. There are shared medical visits available, and we've provided education to providers about how to structure shared medical visits and how to bill for them. We cover medical nutrition counseling and diabetes education. We also provide that. Insulin pumps and CGMs, continuous glucose monitors, are generally covered without prior authorization, and that's in all the lines of business. Unless they're extraordinarily expensive. Okay, next slide. So I'm going into some detail about what our different teams do, and I'll just skip around a little bit here because it's a lot of information. So our care management team has 13 team members. They work to help members access diabetes self-management support services, diabetes education, primary specialty and dental care, and they also help members make appointments and get to appointments. They also help members understand their medications, need for follow-up, and identify gaps in care and medication concerns, and share those with providers. The next slide. The health coaching team is part of our diabetes care program. We have 4 team members. They're registered dietitians, registered nurse case manager, and they're certified diabetes care and education specialists. They support members in self-management of diabetes, type 1 and type 2, and also pre-diabetes, using evidence-based education to optimize members' health and management of chronic conditions. They also support members with their own self-management goals, including medication adherence, improving blood pressure control, diet, exercise, weight loss, and smoking cessation. They also are available for nutrition consults, and they support members pretty intensively with weight loss. So next slide. The CHPW pharmacy team has 17 team members, and they're very active in doing outreach to members with who are on diabetes medications and are either due for a refill or are past due for a refill. They identify opportunities for improved medication management, and they also identify possible drug interactions and share that information with providers and with the members. They do comprehensive medication reviews, and they also share information about barriers to medication adherence, like affordability, side effects, things like that. They do some of the reviews for continuous glucose monitors using the health technology assessment, but usually those don't rise to the level of needing a review if the cost is the usual. So the next slide. More about the pharmacy team. They have to follow, for Medicaid members, Apple Health members, they have to follow the Healthcare Authority single preferred drug list, but they also educate providers about the list in the provider bulletin board and in the Pharmacy and Therapeutics Committee meeting. And they also fax information. They ensure that formulary information is available at point of care. And there are generally no barriers to authorization of medications that are recommended by the ADA if there is a diagnosis of diabetes. They also support community health centers by embedding pharmacists at the community health centers to help with medication barriers for patients with diabetes. They also work at encouraging appropriate prescribing, such as for GLP-1 agonists like Ozempic, that it seems everybody wants that medication now. It is only covered for all lines of business, is only covered if the person actually has diabetes. And if they have diabetes, there are additional criteria if it's not a preferred medication on the formulary or if they're exceeding the dosage limits. Okay, next slide. The CHPW quality team analyzes all the results of all the quality measures, but they also provide the clinical integration solution that integrates test results and claims data with the electronic medical records at the community health centers. So providers can get that information in real time and use it for preparing for visits or during a visit even. They also provide education on using that tool. They host regular quality roundtables for best practice sharing. Those are very well attended, and people are very enthusiastic about all the work they're doing to improve quality. They also have a program on improving health equity related to chronic conditions and other preventive services too. And they support providers in working on those projects. There's financial support and in-person technical assistance. The next slide. The CHPW Community Support Services team has 20 team members, and they're extremely busy. They provide, well, just recently, they started providing an in-house team of community health workers for our members throughout Washington State and for all lines of business. They work in person and go to members' homes and help them. They'll accompany them to visits and help them get services that they need. The Community Support Services team also helps members in person and telephonically with improving social drivers of health. And these are just a general list of social drivers of health, but they do more than that. They also partner with providers and they accept referrals from providers. So that's what I wish I had known that when I was in practice, because they can actually help people get housing. They can help them get gas vouchers. They help them get food. They also work with the school-based partnerships. So they're very busy. And then the last slide is a little more about what they do in partnering with our providers and community organizations. They help members get access to healthy produce and medically appropriate meals after hospitalizations. We still have meals delivered to them after hospitalizations. They also coordinate with community health centers that employ community health workers so that we're not duplicating work with the community health workers. And they support community events and helping members access care and resources. So that's the end of my slides.
Thank you so much, LuAnn. We'll now transition to invite Susan to come on and speak about how health systems can connect with NDPP programs and her role at the YMCA.
Thank you so much, Emily. It's a privilege to be here with you all today, and it was a privilege to be part of this subgroup. I too, Dr. Chen, learned a lot, and it was great to be able to contribute a community-based organization lens to this work. Next slide. So I have an opportunity, as Dr. Kamo mentioned at the top of this webinar, to address a component of the Bree Collaborative guidelines to identify those living with prediabetes risk and helping to navigate them to the National Diabetes Prevention Lifestyle Change Program. I get to take a few minutes with you to share about the program, how to get patients referred, and options for insurance. Next slide. So a little bit of history and context about the National Diabetes Prevention Program for those of you who may not be familiar. The program and initial research was started with a randomized clinical trial funded by the National Institutes of Health and supported by the CDC back in 1996. A total of 1,079 participants experienced a lifestyle intervention that resulted in a 58% risk reduction in the rate of diabetes through this clinical trial. And the goals of the intervention were to help the individual reduce their body weight by 7% and accomplish 150 minutes of physical activity a week. And then in 2005, recognizing that the original intervention was individualized and quite pricey, there was a study to translate the National Diabetes Prevention Program to community-based organizations where trained certified lay people could deliver the program in a group-based model. And from there, the process has expanded in terms of the Y's ability to, well, not just the Y. So this program, sorry, my lens, I work for the YMCA, but as Dr. Kamo mentioned, the National Diabetes Prevention Program is offered by a number of different organizations. I'm just here representing this particular slice. So to note that there are many organizations in Washington State that deliver this program, both in person in a distance learning model and in an asynchronous, fully electronic model. So there are lots of options to meet people from a health equity perspective as they move through need. So anyway, this is the journey story of this particular program. The original translation was done with YMCAs in Indiana and then moved through several different trials and studies, ultimately resulting in Medicare coverage for the National Diabetes Prevention Program. Next slide. This slide just quickly represents the original New England Journal of Medicine article and then the translation deploy study about the Diabetes Prevention Program, recognizing that in a group format, it persists in the great outcomes from the original clinical trial of a risk reduction of between 58 and 71%. Few things tend to get better with our health at an older age, but in this study, we saw that over 60 people were able to reduce their risk by an even greater percentage. Next slide. So the program, for those of you who may not be familiar, is outlined here for you. It is led by, as I said, a certified and trained coach. There are many organizations that conduct and do these certification trainings across the country. Program qualifications, individual, this is for adults 18 and older with a qualifying BMI of 25 or higher, then prediabetes confirmed by a lab value of a variety of different blood tests, and then people can also qualify through taking the CDC AMA prediabetes risk screen, and if they have a qualifying score, that also qualifies them. To note, for Medicare DPP, there does have to be a qualifying lab value for coverage. And then again, these are the program goals. And I hadn't noted, but this program happens and travels over the course of a year. So as community-based organizations are striving to be an extension of care in community, we love being able to receive these referrals to walk through the long journey of lifestyle change, which doesn't happen quickly. The good news is it does happen, but it takes time. So in the course of a year, the individual participates in as you can see on the slide, the first 19 sessions in the first 6 months are weekly. And then they stagger down to every other week. And then the final sessions happen monthly with the goal of having people spend more and more time on their own, practicing these interventions and lifestyle changes that they self-select that are going to fit and work within their life and their lifestyle and their families and where they live, work, and play. So it does take a while, but once people get into it, we hear all the time, this is going so fast. Can I do it again? Anyway, next slide. So this is just a quick note that it is and was fairly groundbreaking to have Medicare cover the prevention intervention in community. So Medicare DPP has been fully available since 2018. Next slide. So a little bit about how to refer to the national DPP. Next slide. Again, oh, sorry. This is, there we go. The self-referral pathway, as I noted earlier, is possible through the CDC ADA risk assessment, which can be found. You can just Google, do I have prediabetes? And it pops right up. In fact, there's even an app for that now. So lots of ways for people to self-identify their risk. And then we, as part of the Bree collaborative recommendations, certainly want to encourage providers, could be any provider, doesn't have to be a physician, to help identify risk, prediabetes risk, through those qualifying lab values. So at point of care, referrals can be made through electronic health records to an established CBO partnership. And then if the provider doesn't have that partnership with a CBO delivering the DPP, there is the possibility of using this link to go to the CDC's website to find a current listing of who the national DPP providers are in that area of service. Next slide. That slide that Emily briefly glanced over earlier was just an example of a very detailed prediabetes care management flow pathway that Valley Medical established, which helps providers not only know the algorithm, but it's built into their electronic health records so that at different points of screening, a flag for referral pops up and patients are able to be referred at point of care. So I'm assuming these slides will be available and you can take a deeper look at that. This is an example of an electronic health referral pathway that was built between Common Spirit, Virginia Mason Franciscan Health, and Washington State. And it is connected by what's called technically a HISP connection from the electronic health record out to extra clinical care services received by the electronic health record system. The Y is used called Buell-Health, W-E-L-L-D. And the next slide shows a little bit of what happens at care navigation.
Susan, we will need to move on to our next speaker in a moment. So if you want to, I'll move to the next slide, but if you want to make a couple comments, we can then move on to the next speaker.
Go ahead. You can keep on going.
Oh,
just quickly wanted to also note that in addition to Medicare coverage, next slide, we know that other policy levers that organizations can pull, there's my timer, are related to Medicaid. We have a pilot happening in Washington State with Molina for Medicaid beneficiaries to have access to this program, and certainly the Bree collaborative guidelines and note opportunities for additional coverage in the future. Thanks so much, Emily.
thank you. Well, now, and again, everybody will have a copy if you signed up for the event, a copy of our PDF slides to see all the details Susan kindly provided. We'll now invite Glenn to come forward and talk about how dentists and dental clinics and plans can use these guidelines to help support patients with diabetes or prediabetes.
Thank you, Emily, and thank you to the Bree Collaborative. We appreciated the invitation to offer the dental perspective on the diabetes report. And for me personally, I've been working on medical dental integration efforts for most of the last 10 years. And this feels like one of the most concrete foundational bricks that we've seen put in place to really help put the mouth back in the body. So I'm just going to quickly highlight a few of the key points from the Bree report, and then we can open it up for questions. The first bit of guidance for dental clinics and dentists is pretty basic. We want to make sure that they're familiar with the American Dental Association's advice on providing dental care to patients with diabetes. And then for specific treatment planning guidance on patient risk and current evidence, we want them to follow the consensus report guidelines. And the consensus report guidelines are developed internationally. There is recent research that has really changed the way dentists diagnose and treat periodontal disease, which is the primary risk factor for people with diabetes. So it's really important to review those guidelines. Next slide, please. And the next thing is to really take advantage of the fact that dentists are another touch point for patient care. And while they are often disconnected from a primary care provider, we feel like this is one of those important opportunities to really reconnect the provider landscape. It's important that we use those dental visits to screen people who maybe have undiagnosed diabetes, but even for those who have diabetes, inform them of their risks that are associated with having diabetes of a dental nature. They can have dry mouth, fungal infections, things that can impact their wound healing. And then the big risk is periodontal disease. There are serious systemic implications and complications related to cardiovascular and kidney disease. And then for those patients who do have periodontal disease, it's really important that they get regular periodontal therapy, which can actually have a positive impact on their metabolic control and diabetes complications. It's important for dentists to screen patients and refer them to their primary care providers, ask whether they've seen their primary care provider at least in the last year, and if not, to encourage them to schedule an appointment. And if they don't have an established primary care provider, help them with a referral to establish with a primary care provider. They should also be asking their patients with diabetes if they are using tobacco. They should be offering tobacco cessation support. And then if they don't offer that, helping their patients who use tobacco connect to their primary care provider for that support. Next slide. In terms of a clinical checklist, they should be supporting good chewing for good nutrition, offering dental rehabilitation to restore adequate mastication for proper nutrition. Dental clinics and dentists can also clear patients for treatment prior to oral interventions or surgeries to avoid hypoglycemia. And they can ensure that the electronic dental record is up to date with current lab values and medications. Next slide. In terms of dental plans, it's really important that if a member of a dental plan is at risk for or currently has periodontal disease, that they're covered for full mouth subgingival instrumentation and 4 supportive periodontal maintenance visits annually. Many people are not aware that the Apple Health program in Washington State recently came up to the standard of care for these treatments for people who are enrolled in Medicaid. They are now eligible for the standard of care in dentistry. Dental plans should also be fully covering dental exams for members with diabetes at least every 6 months. And they should be considering using patient registries and reporting systems for patients with diabetes to track and close gaps in oral care. This is very early. There aren't a lot of dental practices out there that are doing this, but there is pilot work out there, and there are some health centers that have actually implemented periodontal disease registries to help track their patients for oral care gaps and overlay that with their diabetic population. Thank you very much.
Thank you so much, Glenn. We're going to transition to the Q&A. So if anybody has any questions for our panelists, please place them into that Q&A box. But as we are working on transitioning to that, I had a quick question for Glenn. I was hoping when you and I were speaking about this webinar, you had a really great description of the periodontal disease and the relationship with diabetes. Would you mind sharing that with the group who's on the call today?
Sure, happy to. And just to be clear, this was not, I did not come up with this. I heard this from a physician who explained to me that the reason it was important to address the dental component for their patients with diabetes was that the gingival inflammation in somebody's mouth, in their patient's mouth, was equivalent, the gingival tissue was equivalent to the amount of tissue on your forearm. So the way they explained it to me was if your patient had a wound in their forearm or inflammation in their forearm, you'd send them in for wound care. And essentially the same thing is happening in somebody's mouth when they have active periodontal disease.
Thank you for sharing that. I know my background's in nursing, so when you having that description and thinking about the skin on the forearm made me realize how much tissue is in my mouth. Maybe a little scary about how much tissue is there. with that comparison, but I think that really helped me, who I also like to picture things and think things through. So thank you for saying that. The question I'm hoping to pose to the group, the first question is, what is one change in practice do you hope to see occurring by organizations utilizing the Bree report in diabetes care? So if you can pick one thing that you would really hope to kind of come out of this, what is that one thing? I might start with Norris.
Yeah, I think the importance of DSMES, and I think we all have local resources within our clinics, but the DSMES services are kind of unevenly distributed. So love to come up with a system for referral at those 4 touch points that I mentioned in my slides, and remove any barriers, whether it's insurance coverage or transportation or anything else.
LuAnn, did you come off mute?
Oh, yes, I'm off mute. Yes, I wasn't sure who was next. I think what I see as the most important thing would be a way of engaging members, getting them to come back in, get necessary care. And part of that involves the community health worker program, but also it's just sometimes really hard to reach members who don't have stable housing, might not have stable phone service. So I think it's the social determinants or social drivers of health type work that I think is actually the most important for trying to help people access care, and to have get the support for knowing that they need care and to get in for care.
I'd love to build on that, LuAnn, the recognition with the new physician fee schedule, for example, and other authorities that have been released both federally and some at a state level related to the infrastructure and coverage pathway that's needed to pay for community health workers' time, for example, to implement SDOH, HRSN screenings and get them connected to resources that complement interventions like DSMES and the National Diabetes Prevention Program. I think it gets exciting to see this collaborative support, payer initiatives, infrastructure initiatives, care team expansion to be able to fully address whole person health and diabetes risk reduction.
And if I could possibly just build off of what Norris was recommending, the use of diabetes self-management education support, I really think it's important to build and establish those teams within the clinics and make sure that we are referring to both diabetes care and education specialists, but nurses, clinical pharmacists, dietitians, all members of the team, because I think no one person knows everything, and it's really the strength of the team that means that we're going to be providing the best possible care for our patients. Not only the knowledge that all of us have to be able to provide our patients, but relationally, some people match better with different people. So making sure that we have as many people and personalities and ways of speaking and providing information to target our patients, I think is going to make sure that they fundamentally understand the message when they're getting it from 6 different directions. So I think that's really important for our healthcare systems to embrace.
I would just offer from a dental perspective and a plan specific perspective, I think it's important that we start building registries to really understand who's in our population, what their risk factors are, and that we're connecting with them and helping them connect with the rest of the healthcare system.
Great, thank you all. I'm looking at the time. I'm going to ask one more question, and I'm hoping we can kind of keep it concise and quick. What is one thing that you're most proud of in this report or the process of developing the report that you were involved with?
I think from my perspective, just getting a multidisciplinary team, we talk about team-based care for our patients, but it's kind of team-based care for the system and the ways in which it's succeeding at various institutions and organizations and the way the system is not working. We're infamous in the US for having a fragmented system. So I think I commented to the members that, this is not the end. This is the end of the beginning, right? And I'm hoping that through organizations like with like the Bree Collaborative, that we can continue to work and identify barriers and break through those barriers.
Thank you. I saw a lot of head nods, so I'll see if there's if anybody has an additional one they would like to add before we wrap up.
Oh, yeah, I just would like to comment. I agree with Norris, and it was really interesting for me to see the ways that we can support each other in the other pillars of support for people with diabetes. We can all support each other with this. So.
Susan, I feel like I saw that you wanted to come off mute, so I would like to give you that opportunity. Okay, I'm seeing you had no, so I will continue. Well, as we're just working to close, we wanted to highlight a couple of opportunities to engage with the Bree further. We are hosting another cohort of our Health Equity Action Collaborative. If you or anybody that's interested within your organization to engage with us in this space, please email us at bree@qualityhealth.org. If you heard something in the presentation today that you're like, oh, I would really like to work on a project on that guideline or that area of that report, this would be a great space to help develop an implementation plan and learn some skills and engage with people across the healthcare ecosystem like this work group did to help develop a plan that can be placed within your organization and with your team and be appropriate for your clientele. We're hoping to start those meetings in May. You also heard LuAnn talk about those checklists. We have developed checklists for the diabetes care report. We worked with our work group to organize all of the guidelines that are in some of the audiences into a different level system to help you understand, where do you begin in this process? Where might be a place to start, and where do you grow from on the level of difficulty to implement these guidelines? We are also at the Bree trying to provide people with implementation awards. So if you're feeling like you're doing a great job within your organization on excelling on some of these guidelines and getting them into your practice settings, please let us know. We would like to recognize you. We also have a lot of events going on. So again, this webinar is recorded. I will send it out to all of the participants at the end of this meeting once we have it up on our website. We are having a similar webinar next week on complex discharges. We have a webinar coming up on March 6th, so in about 2 weeks, on value-based payment and health equity and kind of navigating that space. I know this space is on diabetes, so we actually have an event April 24th where Dr. Leo Morales is speaking, talking about the work that he has been doing and individuals at University of Washington, connecting to the Latino community in the King County and supporting them doing comprehensive metabolic screenings and working alongside with the community-based organizations, and how University of Washington has a diabetes clinic for Latino population. So we'll hear more from him on that coming up. But we really just want to thank everybody for joining us today and give a huge thanks to our worker members and our speakers, and especially Norris for being a lovely chair who's helped kind of champion the development of this work alongside our staff member, Beth Botchkov. So thank you everybody who's been involved reviewing this or providing any insight. We really, really appreciate everything, and really saw it as an honor to work with each of you. So thank you all so much for attending this webinar. I'll stop recording. And again, please email us if you have any questions or comments that we can help address.